This drug reduces heart attack risk by 40%. Sounds incredible. You'd probably put every patient on it tomorrow. But 40% of what? If your patient is at a baseline risk of 1 in a million, a 40% reduction means you've gone from very unlikely to slightly very more unlikely. That headline is doing a lot of work, and almost none of it is for your patient. Today, we're talking about two numbers that cut through the noise: NNT, or number needed to treat, and its evil twin, NNH, number needed to harm. These are your receipts for every trial. So why do number needed to treats and harms matter? Well, pharma loves relative risk reduction. It sounds impressive. It photographs well on a slide, and reps will quote it with a level of confidence that should concern everyone in the room. But relative risk reduction is a ratio. It tells you how much better a drug performs compared to placebo, as a proportion of baseline risk. The problem is that it completely ignores how big the baseline risk actually is. Absolute risk reduction gives you the raw difference in event rates, and NNT is just the inverse of that number. It forces you out of the world of percentages and back into the real world of patients. Because in clinical practice, you are not treating a percentage. You're treating a Mrs. Johnson and a Mr. Thompson and those 263 other people in your waiting room who are statistically not going to benefit, but deserve to know that. Let's consider a meta-analysis that had aspirin for primary prevention as the target. No prior heart attack in patients or no prior stroke. We're pulling this from a meta-analysis of 13 randomized trials with over 164,000 patients published in JAMA of 2019. The composite cardiovascular outcome here was CV death, non-fatal MI, and non-fatal stroke. Event rate in the placebo group was roughly 3.9%, and the event rate in patients that took aspirin was roughly 3.5%, an absolute risk reduction of 0.38%. So let's divide 1 by 0.0038. You get a number needed to treat of 265. What that means practically is you need to give aspirin to 265 patients to prevent one of those cardiovascular events. Now, is that good enough? That's really the wrong question. The right question to ask is, what does it cost you to get there? So let's look at the opposite, which is number needed to harm. It's the same formula, same math, with a different endpoint. And now we're considering the harm that an intervention does. In that same study, we looked at major bleeding, which was defined as any clinically significant hemorrhage. This occurred in the aspirin group at a higher rate than placebo of 0.47%. So if we divide 1 by 0.0047, we get a number needed to harm of 210. Sit with that for a second. Treat 265 people to prevent one cardiovascular event. Cause one major bleed in 1 out of every 210 people you treat. Your number needed to treat and number needed to harm are essentially the same number. You're trading the harm for benefit at nearly a 1-to-1 ratio. That is not a ringing clinical endorsement, and probably leads us to not using aspirin for primary prevention. So in this EBM series, I'm trying to give some real-world examples to help make sure things stick. Number needed to treat will be impossible to forget when we apply it to the residency match. A family medicine program has 6 open spots, and they send out 90 interview invitations. Their NNI, or number needed to interview, is 15. 15 interviews to yield 1 matched resident. Now, flip to the applicant side. Every interview is a flight, a hotel room, a rental car, and a dinner where you try to seem relaxed while internally rehearsing your answer to the "so tell me about a time you received difficult feedback" question.
Okay, well, this is going to make dinner really awkward.
The question becomes, how many programs do you, as the interviewee, need to interview at before one program says yes? That's your personal number needed to treat. The concept is identical. Out of everyone exposed to this intervention, drug, interview, or aspirin, how many need to go through it before one person has a benefit? And if interviews occasionally result in someone getting hurt, say a catastrophic dinner conversation, that would be your number needed to harm. Number needed to treat and number needed to harm. Learn them, quote them. They're going to be on your board exams, I promise. Use them at your next journal club when someone leads with a relative risk reduction. And the next time a rep slides a 40% risk reduction across your desk, you know exactly what to ask for. Until the next time, this is Dispenses Written.